Good evening.
Good evening.
Hello, everybody.
Hi, Elaine. How are you?
Hi, Elaine.
Hello. Good. Just checking the mic.
Hey, Elaine.
Hello, future nurses.
Hi, Professor.
Hi, Professor.
Okay.
Hi, Professor.
Hey, Professor.
Okay, let's get this out of the way. All right, so who wants to start? First question. Let me call on Sylvia.
Can I go, Professor? I have a question.
Sure, go ahead.
So the blueprint says that we need to know the tumor markers. So we need to know each tumor marker and what they're for.
Don't go into that detail. Just generally, what are tumor markers for? Because like I said, it won't on the NCLEX, it's not going to be about chemo and stuff. So generally speaking, what do you know about tumor markers? What do they do?
They monitor
Not
if
specific
chemo.
about what.
I'm
All
sorry.
right. So what did you learn in class? So it was to.
It monitored if the chemo was working in like specific areas or like.
So it was specifically used to evaluate response to treatment, right?
Right.
Effectiveness of the therapy, right? And also whether or not to determine whether or not the cancer is recurring, right?
Mhm.
Yeah, that's it. Don't go into much detail about
So what would a sample
to
question be for that?
yeah.
Just to know that I'll be able to apply it, because I think I know it now, and then we have a question and I'm just like, what?
Yeah, I mean, like I said, that part of what marker is used for which cancer, I don't think that's nursing.
Okay.
Next. Who is
Hello.
Hi, Sophie. Yeah.
Hi. I'm so sorry. Did I miss anything? I just joined.
I know. I was just asking if anyone specifically had a question so we can get the ball rolling.
Okay. Because I've been doing the notes for the final review, and I have some. So my first question is the question about the consent nurse's role. I only found the only answer
Right.
in the book is that on the day of the surgery, she just has to verify. She has to be present and verify the signature of the patient. Is that it? Or is she doing anything else?
Well, remember the questions on the tests are always scenarios, right? So
Mhm.
it's always clinical application. So specifically with regards to consent, what is the nurse's role? Are you giving informed consent?
You're witnessing the
No,
signal.
this is the signature. That's it.
Okay, but when you sign as a witness, what are you witnessing to?
You have
What
to
does
make
the book
sure the
say?
patient, you have to make sure the patient understands what they're signing, if they're coherent, if they know they have an option to decline.
Okay, is it your job though to determine that they've been informed?
No, you just have to be present and like assert that the doctor has explained and that the patient is aware of all this. Like you're present as a witness to attest to these things were done. The patient, the
Because
patient.
remember, the surgeon gets the informed consent, right?
Yes. Mm-hmm.
Right. So they explain the procedure. So once they get consent, all we're really getting is what? Just a
The signature?
right.
Okay.
So the next question is, what does that you as signing as a witness? What are you really witnessing?
That it's the patient signing the consent and not the family member or someone else?
Go ahead, BB.
I said that you're witnessing that it's the patient who is signing the consent and not someone else.
Okay, what else?
Basically, it's like you're an advocate for the patient because you're there to verify that the information that the
Gemma,
patient.
your audio is cutting.
Okay.
Hello?
Yes,
Yeah,
I'm saying by
your audio was
I don't know what happened.
cutting.
I guess it's not working.
Okay, you're here now. Go ahead, proceed.
Signature and for the surgery, the nurse is acting basically as an advocate for the patient, making sure the patient understands what the purpose of the surgery, the information that the surgeon gives is correct, and the patient is allowed to ask questions if to make to clarify information that is not that he or she might not be so certain about. So yeah, those are some of the responsibilities of the nurse.
All right, you got the gist of it. Okay, so here's the paragraph where that answer is found. So this is page 309. So this is informed consent right here. So it starts off with what constitutes consent, and they gave you 5 conditions that met, 3 conditions rather, that must be met. And then here is the role of each practitioner. So the surgeon is the one really getting obtaining consent. It's the surgeon. The nurse is merely obtaining the signature. Actually, it doesn't have to be even the nurse. It could be another person, but most of the time we're the ones ending up getting the signature. The surgeon could have made this easier for us by, since he's there explaining it, he should go ahead and obtain the signature. The problem is he can't sign as a witness though. So that's why they end up passing it to the nurse, because they themselves cannot witness because they're the ones doing the surgery. So that's how nurses end up obtaining the signature, because right there we can also sign as a witness. But here again is, besides watching the patient sign it, what else are implied?
If the patient is not forced.
All right, very good. That they really understand the information. Okay. And here, if the patient is, so your duties are, if your patient's unclear, so if they gave you any indication that the consent wasn't full because they did not know the full information, then that you can then call the physician, the surgeon, and then ask him to answer the patient's questions. Okay, and then you can proceed. There's also a item on the blueprint about when there are exceptions, and then what you do if let's say we have a minor, for instance, or mentally incompetent patient, or if we have a blind patient, right? Or in cases of emergency, um, what are the acceptable practice? Okay? Like here, for instance, this is an emergency, so a patient needs immediate medical treatment. So is consent really necessary?
No, and that's the only exception I found in the book. Is there any other one besides this one? Like you said, a blind patient.
Well, blind patient doesn't mean they can't give consent, right? They can still give consent, but in the case of the signature, how can what changes do we do if, let's say, the patient can't write, can't read, and therefore can't sign? So what are the exceptions?
Okay, so these are the exceptions. Okay.
Okay. Meaning, how can you get consent in those situations?
True. They can read, they can write. Yeah, you can get it.
Yeah, but there doesn't mean they didn't give consent though.
They will mark an X.
Okay. And then in such case, how many witnesses do you need?
2.
All right, 2 witnesses. Let me see if there are other exceptions. No. Okay. And make sure. How about this one?
So that's
Let's say,
that's the exception as well.
yeah, I mean, if let's say you forgot to have the patient sign consent, and you've already administered the Demerol or the Versed, you've already given it,
Okay.
and you forgot, but the patient's still awake,
Mm-hmm.
and we still get the signature.
No, because they're under the influence.
Yeah.
Right, because we can't verify, right, that whether or not they were really still there because you've already given the medication. All right, so those are possible scenarios. Next question.
Chapter 29, I couldn't find anything for that question. Assess for presence and causes of blood disorders.
Assess for what again?
Presence and causes of blood disorders. Chapter 29, I couldn't find anything on that.
That's in the table 29-4. It's a whole bunch of questions.
29 what?
29-4. There's a whole table full of questions to ask the patient to assess for the presence and cause of blood disorders.
Um, page 594, yeah.
Well, since we're already in that chapter, Professor, can we just discuss the clotting mechanism? So I know we're supposed to know the route for the extrinsic pathway and the intrinsic pathway, but like, can you give me a sample question in which I will be able to apply that so I'd know like what or how I would need to apply it?
Okay, it has something to do with, it's still the same figure this time, figure 29-4.
Right. No, I know, I see the figure, but like, let's say if you ask the question, do I need to know, okay, well, the factor 7 is activated. Like, what would I, like, what is a sample question?
Okay, so it has something to do now with, because of course, no patient will ask that, can you explain to me the extrinsic and the intrinsic pathway? It's not going to be like that. It'll be about the medication that they're taking. Or it could be, if it's not a patient, it could be the student nurse. Right? So you have a scenario, a student nurse asks blah, blah, blah. So what is the nurse's best response? So with each anticoagulant you're giving, so let's say it's under DIC, based on what you know about the pathway, what are the, if you give me a summary of how you form blood clots, Who'd like to volunteer?
I could try.
Okay, go ahead.
Okay, so obviously there'll be an injury to like the vessel, the vein, or whatever. And then you'll have, so there'll be exposure to the now intrinsic pathway. The vessel is the extrinsic, the inside of the, or the damage is the intrinsic pathway. There'll be adhesion. So I guess those little, I watched a video and they were like these little gray platelet things. Hold on, I'm sorry. Sorry for the noise. These little gray platelet things, they attach to where the vessel is broken. And the, I guess the platelet cells aggregate there and they form a clot with like the fibers and it makes a fibrin clot.
So, all right, let's summarize it. So there's two pathways here. So as soon as the vessel is injured here, in both cases, extrinsic and intrinsic pathway, so you have a vessel injury, tissue factor is automatically released by the injured vessel. This could be a
That's the
capillary,
great things, the tissue factor.
right? So this is the fastest way to form a clot. So the extrinsic pathway is as soon as tissue factor is released, then this will attract factor 7 and then forms a complex with the tissue factor. And then once formed, then that activates platelets. And then more platelets comes and then they stop at factor 10. Meanwhile, at the same time, this pathway right here is also occurring. So the same trigger, you still have the tissue factor here, but then it has a longer path. So it has a longer succession of activating a series of clotting factors, but they still end at factor 10. So these two pathways now, the extrinsic and the intrinsic pathway, meet at this point of factor 10. When factor 10 therefore is activated, then there will be prothrombin activation. So prothrombin becomes thrombin now, right here. So this is now what you need in order to catalyze fibrin. So once you have fibrin, then this will hold this clot together. These strands you see here, these are now the fibrin holding the whole thing together. This is now a permanent clot. The clot you formed right here at the extrinsic pathway is a very unstable clot. So it's just a temporary plug. Now, how does this all factor into the question? Well, we have how many bleeding disorders? We have TTP, ITP, what else? HIT and DIC, right? So we have 4 under chapter 30. Now, if you notice on the blueprint, the topic said recognizing lab findings, right? For each one. Because again, you're the nurse assessing the patient. So you'll see these patients' labs. So when you pull up the labs, what do you expect to see in these patients? Let's begin with your platelets. What happens to your platelet count?
Lowers.
All right, it drops. Where did the platelets go?
They're all forming that clot.
All right, so the platelets are forming clots. That's why they're disappearing. So therefore, what happens to your bleeding time as a result?
Shortened.
Will it decrease? Will it shorten or becomes prolonged?
If platelets are missing, it's going to be prolonged.
Okay, so let's say we go to chapter 30. Let's apply it to each one. So, well, where is thrombocytopenia?
Professor, you're not sharing your screen, you know, so we can't see what you're showing us.
I'm seeing it.
Oh, okay. Sorry.
Okay, so here are now your bleeding disorders. So we have ITP, TTP, HIT, DIC. So in ITP, what's wrong with the patient? This is immune thrombocytopenic purpura, or also called idiopathic. You develop hello?
A breakdown of the amount of platelets.
Okay, so you are developing antibodies against your own platelets. Okay, so we know platelets normally survive 8 to 10 days. What happens when you have ITP?
Maybe 5 to 6 days.
All right, so now it's now shortened. So the platelets here don't last long. So that's what leads to the thrombocytopenia. That's what leads to the bleeding disorder. Now, therefore, when you go to treatment now, manifestations first. If you look at manifestations, obviously the patient has signs of bleeding. They will differ now in the laboratory. However, they will have similarities because bleeding disorders tend to have the same manifestations, the same lab results. So you as a nurse, when you pull this up on your from your EHR, so you see here ITP, TTP, HIT, they all have low platelets. Okay, so regardless of the bleeding disorder, if you have a bleeding disorder, platelets always drop. Now the hemoglobin here won't necessarily drop until you're actually bleeding. Okay, that's why they say here normal. But if you look at the bleeding times here, this is DIC on number 4. And what is D-dimer?
That checks your clots.
It shows
Okay, this is called the
The result of platelet disintegration.
yeah, right. Remember figure 29-4 on chapter 29 at the end of the clotting cascade? What happens after a clot is formed?
D-dimer.
Clot lysis begins, and then when you have clot lysis, then you have D-dimer, because D-dimer is a fibrin degradation product. After you form fibrin to hold together a clot, the body now starts to dissolve that clot, leaving, once you break down fibrin, what's left over is D-dimer. So here in TTP, ITP, is this ITP? Yeah, in ITP and TTP, look at your D-dimer. Why is it normal? Or maybe a little bit increased? Are you forming clots in an ITP? No, because the nature of ITP is you are destroying your platelets. You are forming antibodies against the platelets, so therefore, are you clotting or are you bleeding?
you bleeding.
You're bleeding.
So
You're
let's look at the definition now and pathophysiology of TTP. So we looked at ITP, it was platelets, antibodies against platelets. So basically your own body is destroying the platelets. That's why these guys have lower platelets, plus they'll have splenomegaly, because the dead platelets are recycled over the spleen because there's a lot of them being killed. So now you have increased spleen size. In TTP, this is a thrombotic thrombocytopenic purpura. So the problem here is inappropriate bleeding. If you look at the pathophysiology description, it's not the same as ITP, meaning your clots here, your platelets form a clot inappropriately, meaning there's no reason for your body to form clot, but then you're forming blood clots. However, when you do get injured, and then now you need your body to clot because you have an injury, then it doesn't clot. So that's the problem with TTP. There's inappropriate clotting, but then when you need them to clot, they don't clot because they've already used up all the platelets. So that's why you'll see in the labs, look at the D dimer in TTP. It can be elevated because you are forming clots here, or it can also be normal. If you go to HIT, in HIT, you have an antibody against heparin. When exposed to heparin, you have an HIT antibody. So your HIT forms a complex with platelet causing clot formation. Because they're doing so, meaning every molecule of heparin will attach to a platelet forming a clot. So therefore, by so doing, they use up all the platelets here. The first type, because there are two types of HIT, the most common one is it starts happening, it develops within 24 hours of exposure to heparin. There's also another type wherein it's later, meaning the symptoms occur, the process occurs later after exposure to heparin. But in both cases though, the platelet count drops below normal. Now, what's dangerous about this is sometimes it's not evident. It's easy to see if, let's say, the platelet count becomes below normal. So let's say you started with 200,000, correct? Let's say your platelet count on admission was 200,000, which is normal. If it drops by 50%, it's easy to see because now it's 100,000. That is obviously below normal, correct? However, what if you came in with a platelet count of 400,000? If it drops by 50%, is 200,000 normal or not?
Yes.
It's normal. So will it flag you up on the labs? Will it show as alarming to you?
No.
Typically, no. Okay, because it's still within normal. However, you have to compare it with your pre-heparin level though. Meaning on admission, it was 400, but then you gave heparin yesterday or the day before. Now look at your platelet drop. It's now more than 50%. So that is now still a diagnostic of HIT. So if you look here in HIT, because you are forming clots, this is what makes HIT so dangerous. Because why did you give heparin in the first place? Why did you give the patient heparin?
To prevent the clotting.
Prevent the clotting.
Trying to prevent clots, right? But what's happening to this patient now?
They're clotting?
They're forming lots and lots of clots. And all the time you were expecting them to prevent the clot, but then they're forming clots. So because you have a lot of clots formed, then you have a lot of clot breakdown also. That's why your D dimer rises. And in DIC, let's look at DIC.
I'm sorry, Professor, about HIT. So what happens is you give heparin, the heparin attaches to a platelet and it doesn't work?
Well, the patient happens to have an antibody. They have a HIT antibody. They forming an antibody against heparin, meaning if they have that antibody, heparin binds with the platelet, forming a complex which now becomes a clot, meaning they stick to your platelets, forming a blood clot. The incidence is rising because of more we're using heparin more often now, but it's just a luck of the draw because we don't screen people for the HIT antibody. It's expensive. I don't know if someday we will, but right now we're not screening before we give heparin. So all we can do right now is monitor our patient's platelet count, because you can still save the patient. If you catch it early, then you simply stop giving heparin and then use another anticoagulant instead. So under interventions, you'll see that they'll use argatroban, which is now it's now a thrombin inhibitor, but it's not like heparin. Meaning the patient still needs anticoagulation, right? That's why we gave heparin in the first place. But you can't continue giving heparin. So now you have to use another one, argatroban. And DIC, where they put DIC? Anyway, so DIC has two phases. The triggers for DIC are usually severe injuries like trauma, bleeding, hemorrhage, cancer, sepsis. Yeah, those are the most common, like abruptio placenta. I'm sure you guys discussed this in OB, right? You remember? In placenta previa or abruptio placenta. Those are also triggers for DIC. Yeah?
Yeah, yes.
Yeah. So what happens is the patient, the DIC has two phases. There's a clotting phase, and there's also a bleeding phase. The clotting phase isn't very fatal. It's really the bleeding phase that kills the patient, because what happens in the clotting phase is the clots are microscopic. They form microthrombi, so they're not really that big to form a clot that would cause a PE or a stroke. So they're tinier clots and widespread. So they tend to block smaller organs like the spleen, mostly GI organs. And then because they use up your platelets and your clotting factor so fast, and then you run out of it, and then it causes bleeding afterwards. So that is how you use the, meaning to answer the question, you needed to understand the clotting cascade. Meaning it's not necessarily that the question is about the clotting cascade, but if you understand how it works, then you can understand this table. Does that make sense? I mean, or if you want to memorize, yeah, you can skip that and then just memorize table 30-12. But to make it easy, if you understand the clotting cascade, what happens and what is the ending step, which is again clot lysis. As soon as a clot is formed, clot lysis begins. Next question.
I didn't find the principles of pain assessment for dementia in patients.
Principles or the tool?
the outlines or principles of pain assessment for dementia so that if the tool that'll work too.
Okay, here. So how do you, first of all, assess pain in a patient with dementia who can be nonverbal? Or in the same way, doesn't have to be dementia. So what if we change this to a cognitively impaired patient or an unconscious patient?
Is pain scale?
So
What page are you on?
This is 126.
Thank you.
So here is the principle I'm talking about. So that's table 818. Like, for instance, never assume unable to communicate. Or this one. Is it acceptable to obtain information from caregivers about pain?
No.
What does this say though?
Caregiver reports of pain from professional and family caregivers.
That's exactly what this is saying. So since the caregivers, whether it's the family member or the patient's doctor, for instance, the provider for this patient who know this patient best, can you obtain that information from them?
Well, this says yes.
Yes, Professor.
That's an acceptable practice. So here are your cues for pain. So they may be grimacing, frowning, rubbing a painful area, groaning, or they're restless. All right. So these are what what I meant by how do you assess. What are your pain assessment techniques for marginalized populations? Okay, those who are unable to tell you that they're in pain, which we have a lot in nursing homes. Okay, long-term care. These patients, are very vulnerable to pain, and the problem is they're under-medicated or unmedicated. We don't know how to assess the presence of pain. Did I put this on the blueprint? Say you have a drug addict admitted and they're complaining of pain.
It says managing barriers to pain management. It has addiction there, so I guess.
Okay, so let's say you have a patient with a known, and it's on the chart, okay? They abuse opioids for years, and they're telling you today, I need something for pain, please.
If it's prescribed, you give it to them.
You'll give it to them, Professor.
If it's prescribed, you give it to them.
Right, because according to McCaffrey, pain is whatever
The patient says it is.
Yeah. I know it's hard to accept because we know, we can't tell whether these patients are faking it or not. But at this point, what is your duty?
Give the pain medication.
Right. Sadly, yeah, that's all we can do. Look at this. Really no evidence providing opioids to these patients makes their addiction worse. And what does his next statement say? In fact, the stress of unrelieved pain contributes to relapse in these patients.
However, Professor, are you there? Professor?
Yes, Shamian.
Oh, you know my name, huh? I know you can see it. I had a patient in a hospital a few years ago. We know that they're using it. We know that they're addicted. What you find is that they're jumping out into the hall before time for the medication and demanding it. So although they need it and they can get it, the difference is they have to wait with the schedule. If we gave it, whenever we gave it, not because they jump out in the hall and want it, they can get it.
Yeah.
And believe it or not, they lose their mind during that waiting period. They drive you crazy.
I understand that. The book never told you to give it before it's due.
I know, no. I'm not disputing. I'm just saying something. I'm just adding. You know what I'm saying?
Yeah.
Yeah, I'm not disputing.
Okay. So here, there's another thing you should remember, because sometimes we look for vital signs changes before we give pain medication, meaning we're looking for proof that the patient really is in pain. Can we do that?
Yes.
Well, how do you reconcile that though with what McCaffrey said, that the most reliable assessment of pain is the patient's self-report, which is entirely subjective? Because if you do that, if you're looking for vital signs changes before you give pain medication, what you're doing is basically asking the patient, let's say I'm your patient and I ask you, can I have some pain, please? And then you're telling me, prove it.
Oh.
Right? That's basically what you're saying. If you take my vital signs and then base your assessment, no, I don't think you're in pain because look, your vital signs are normal. Can we do that?
No.
No.
No. I'm just looking for the statement to back that up. Okay. This is interventions already. I'm looking for the assessment that says meanwhile you can ask other questions. It'll take me a while to find it. It's in a chart or no, a table.
Professor, what you doing over this Wednesday?
Well, I'm planning to do recordings tonight and tomorrow night, and hopefully I'll finish it by Wednesday before class. So it'll be whatever you guys want, but I hope to get all the recordings done before class on Wednesday.
Okay.
Any guidelines on the cardiac retake? I might have missed that.
Oh, this is the same blueprint, except I'm taking out all the blood transfusion topics. So it's the same topics, just different questions. Except the blood transfusion part, because I moved it all to the final.
Okay.
But remember, they're still all application questions, okay? Assessments, interventions. Because especially in the case of chronic pain, let's say your patient has chronic cancer pain, do we still expect vital signs to change in chronic pain? Because the body adapts to the pain. So initially, for let's say a patient who is post-op, yes, of course you'll see some vital signs changes there. But even with a acute post-op patient, do the vital signs remain high because they're in pain?
No, your body adapts.
Necessarily, right? Exactly. So you can't really use vital signs to do that. Right here. So basic principles of pain treatment. So follow principles of pain assessment. So table 8-5 will go to that shortly. So pain is a subjective experience. Pain is not only the best judge of his or her own pain, but also the expert on the effectiveness of each pain treatment.
So let's say you have a patient that you've given morphine to for, let's say, a back pain, and you follow that up with Tylenol, and they say Tylenol didn't work. Do you go back to morphine? I thought we taper them off.
Just explain to them that you're using different modes of therapy, because the recommendation is always use a multimodal approach, meaning although yes, it's true that opioids provide faster relief compared to non-opioids, correct? But it's also true that both of these medications work in different ways. So let's say in the case of ibuprofen, right? So ibuprofen is an NSAID, correct? So it's an anti-inflammatory, non-opioid analgesic. So the way it relieves pain is over time, meaning it won't give you immediate pain relief now. So it does it over time. So if you're giving, let's say, you have a swollen knee, for instance, okay, from either arthritis or let's say septic arthritis. So you have an infected knee, and the pain there is really from the increased swelling, okay, and inflammation around the joint. So although opioids will give them pain relief now, however, remember opioids only work by masking your interpretation of pain, right? So because all these interventions are based on the gate control theory. So if you close the gate, then pain impulses can't pass. So in the case of opioids, since they mess with your head, that's why you have euphoria. You have you don't feel, you can't feel your face. You feel so numb when you feel so high. It's because it's altering your perception of pain. Whereas the NSAID or the other analgesics work differently. So they hit more on the reducing the inflammation because they are anti-inflammatory. So therefore, long term, they are more effective in treating the patient's pain because it's getting rid of the inflammation, which is causing the pain, whereas the opioids are simply masking the perception of pain. So which one is more effective over time?
The NSAIDs.
Actually,
Also, of course, this depends on the scenario. So let's say in an acute surgical incision, for instance, we know it takes time for the surgery to heal. So until um, that incision heals, of course, the patient will have pain. So in that case, we can't hurry it up. And we cannot suppress the inflammation either because we need that inflammation there in order to keep the healing going. Okay, we can't suppress it. But in the case of autoimmune diseases like rheumatoid arthritis, the inflammation there is what's causing the pain, meaning there's no physiologic purpose for the pain. It's not like we're trying to treat an incision. Okay, in the cases of chronic autoimmune disorders like that, like Crohn's or rheumatoid arthritis, right? So those are unnecessary inflammatory flare-ups, which we need to suppress. So here's table 8-5, another principle of pain assessment. I think this was, who asked this earlier?
That was me, Tasha.
Oh, okay. So here, do not rely primarily on observations, okay? If the patient, unless the patient's unable to verbally report pain. Here, pain can exist even when there's no physical cause. Let's say the doctor ordered x-rays, MRIs, whatever he wants. He can find no justifiable cause of the patient's pain. Can he then say the patient's full of S-word?
No.
No. Although they do that, but they shouldn't. Okay, and then we have tolerance, which is varying per person. All right, so for the exam purposes, you have to think like this, okay? I don't care what you do in actual practice, how you cuss your patients out, which I hope you don't do. But these are how we answer pain questions on the NCLEX or on the exam. Okay, you have to be the kindest, most considerate nurse, the most caring nurse when it comes to pain. And so vital signs here, if you're still stuck on vital signs can't be used to to prove the presence or the absence of pain. However, vital signs, you can use it for other conditions, meaning on top of pain, what else is going on in the patient? Does that make sense? But it shouldn't be used as a basis for determining whether or not there is pain. Next question.
Okay, I guess I'll go again. So I don't know if anyone wants to review cardiac, but I had trouble with the dysrhythmias. Can we go back through dysrhythmias, like a synopsis or quick
Doesn't
run?
have to be a synopsis. I mean, this is tutoring. You can do whatever you want.
I mean, I don't know if everyone's on board with that, but I had trouble with that. Please.
Well, you're the only one brave enough to ask, so nobody else is asking. So, all right. Keep it basic. So just you have here. So the strips that are on here, just like the first exam, I'm using the same strips, whatever they say here. All right, so let's begin with sinus dysrhythmias. Why are they called sinus dysrhythmias? Sinus Brady and Sinus Tach. What happened?
I begin with the sinus atrial node.
Because
They originate in the SA node.
all right, they are sinus because they have P waves, they have QRSTs. They're basically normal except for the rate. In sinus bradycardia, the rate is under 60, and in sinus tachycardia, the rate is over 100. But basically, if you do all the measurements, they are within normal limits. The PR interval is normal, QRS duration is within normal. The ST segment is isoelectric. The T wave is positive deflection and not tall or peaked. So therefore, what do we need to do? So this is sinus brady, sinus tachy. So other interventions, which again, I don't like the setup of this text. You have to scroll all the way down here to look for the, right here. So how you study is it's always about the cause, because here under interventions, it specifies for the patient with symptoms. Therefore, you only treat if the patient is symptomatic. And the treatment is IV atropine. Otherwise, if they have no symptoms, doesn't mean we leave the patient's sinus bradycardia alone. We look at the clinical associations. So if the drug, if some of these causes are present, so let's say the patient's on beta blockers, maybe the patient is constipated, or maybe the patient has hypothyroidism. Okay, so these are the common causes of sinus bradycardia. Valsalva maneuver alone, we have several. What are other examples of Valsalva maneuver besides giving birth to a turd?
Repeat the question, Professor. You said what other purposes due to Valsalva maneuver?
No, what are the other examples of Valsalva maneuver? Meaning everyday things you do.
Examples of sinus Valsalva when you
Use the restroom.
Is that an example? Or
When you have the hiccups, when you try to pop your ears on an airplane.
all right, so those are all Valsalva maneuvers. Let's say you're blowing through a straw, which is a common maneuver we ask the patients to do. Okay, when they have SVTs, so we ask the patient, the doctor says, okay, do a Valsalva maneuver. We give the patient a straw. When you're whistling, okay, to whistle, you're actually holding your breath, right? You took in a deep breath and then you held it. So that's a Valsalva maneuver. Singing. Singing really high notes, right? You're belching out songs like that for a long period of time. That's Valsalva maneuver. Anyway, enough of the Valsalva maneuver. So we consider the patient to be symptomatic when they have these. So fatigue, dizziness, chest pain, syncope, and of course the vital signs. If the vital signs show that the blood pressure is suffering, meaning it's now less than 90, then that is considered symptomatic, definitely. And then that's the time you give IV atropine. In the case of sinus tachycardia, the same thing, because this is sinus. So it's normal pathway, same as sinus brady. The only thing wrong is the rate. This time it's too fast. And there are many conditions that will lead to sinus tachycardia. So we have these triggers right here, both physical and psychological. So in the absence here, in the absence again of symptoms, then the underlying cause guides the treatment. So if it's any of these, then you treat the underlying cause if you can identify it. If you can rule out these possible causes and they're still tachycardic, then you consider medications to drop the heart rate now. That's using beta blockers. Adenosine is reserved only for SVT or calcium channel blockers, same effect as beta blockers. And for severe patients, let's say it's already related to Afib, then we do cardioversion. And just do the same thing. For every dysrhythmia, do the same thing. What are possible causes of these? Because that's what you're asked to do every day. So if you're on a telemetry floor, you look at the patient's rhythm, we don't go for the med cart right away. We go assess the patient, see how are they tolerating the dysrhythmia. You're expected to know what are possible causes here. So that's where your clinical associations come in. And then based on the symptoms, you decide whether or not to give drug treatment. If not, you eliminate the cause, and that is your action. In the case of PACs, for instance, here in PAC, what is the clinical significance? It says here, if the patient is healthy, PACs are no big deal. However, if a patient has an existing heart disease, PACs, if they're frequent, may be a warning of a more serious dysrhythmia coming. And treatment of PAC, again, depending on your symptoms again. So if the patient has symptoms, then you treat. If not, no, just eliminate the cause. So causes here identified are electrolyte imbalances, hypoxia, or even here, coffee, smoking, or alcohol. So that's simply, if you identify that, then you eliminate that, that may be all you need to do for a PAC. But treatment-wise, here, beta blockers, if the PACs don't go away. And then you do this. Yes, go ahead.
Professor, I just want to say something. I appreciate what you're trying to do for us, making yourself available and people asking questions. There's just something at the back of my mind that I'm wrestling with. We read the book, we're told to read the book, we read the book, that's cool. We come to these sessions and we're getting little ideas as to how to answer questions. What's missing are sample questions. So let me explain what I mean. I can teach a child the alphabet and then combine letters, teach a child to read. I have to also teach the child word attack, how to use the phonetic system to attack the word. What does this have to do with what we're doing here today? I wish that at some point, these questions that require some serious application of material that we're barely understanding, that questions, you would come with some questions, not so that we say that that's the question you're going to bring, but you bring the question and we're able now to actually see the application to a physical question, more than just hearing that the question could be asked this way. Some of us learn by seeing, like, here's the question. How do we apply what we just read? If we learned it, the application. If that is done a couple times, I don't know if my peers are in agreement.
I agree.
If we see a couple of questions, you see, here's the problem, Professor. And I appreciate you taking the time. I'm not downplaying that at all, so thank you. But we are sent to read the book. The teaching and the explanation is sometimes not as much as we'd like. And I'm thinking that maybe it's the constraint of time on the teacher and on the professor. Understood, fair enough. Because of that, Professor, I am thinking that questions, let's see these questions. Let's learn to attack it. Like I come from teaching, I had to teach my children word attack. I need my professor to teach me question attack so that when I come to do this exam, the questions and we're not blown away by them.
No,
Because
it makes sense. That's
It makes sense, Sharian. Just to interject.
we're reading. You're asking us to read. Reading.
We're
But
reading
we cannot teach ourselves. We can't teach ourselves. There are things that we really don't understand. Professor, if we start to hit you with questions this evening, you might be here till tomorrow. But if you come with questions per topic and say, okay, guys, you've read, here's a question. What is this question asking? How do you attack this? We need you to train our eyes, not because we're lazy and we want to be spoon-fed, but this is application and it's not always easy. You know what I mean?
Yeah, to interject, Charmian, what I would dare say is that we have been acclimatized to a certain line of questioning. Now we're doing more application synthesis and breaking up of materials that maybe was not reinforced initially in the method of questioning that we were given. So it's kind of a shocker to now be asked extensively to apply critical thinking skills in every aspect of a question when you were initiated to do simple recall cognitive level questioning in comparison to higher level. The level of questioning is what maybe is jarring some of us, like myself now, in the approach to the question, because I'm not very quick in grasping concept. I will write my way through, I will argue my way through, but it takes time to apply the information and to tear it apart, to put it back together to give you what is expected. So based on what you're saying, for me, I analyze and summarize it since we have had Professor that this is our challenge. Our line of questioning was not always along this path. So now having to tread this path and to change your orientation in this short time is fairly challenging.
And I'll add if I may, and I really would like students to step up and say what our challenges are, because sometimes we're a little shy. I will warn you, Professor, that there would be probably significant failures again if this application process, even though it is to our benefit, if questions travel this line on Friday, you can have a repeat of what happened before. And I am not saying that my peers are dumb, they are not. But we are overwhelmed, if I should choose that word, because this process is important, and I see it's important, but it is coming in at the tail end of the semester. And the exams are being set up along this line of questioning. I would ask, seeing that this is happening on the tail end, that you and Dr. Grant take into consideration, especially us, that this, even though admirable and the perfect way to teach, we need to apply. The masses were not traveling that path. And so if your questions could be mixed, that would be fantastic.
Or even if he posts questions now during these tutoring sessions, so that you're able to
from some questions to kind of post, yeah.
If we can go over a topic, like let's say somebody
Brady's party is, I'm like, okay, I thought I knew it. And now when you go back and you ask the question,
exactly.
Right. Okay, what does that mean? What am I looking for? I don't know how to break it up.
We were not trained. We were not trained. And then we are expected to answer these questions. And guess what? When you don't hit that mark, those points, you have to repeat this class. We end up walking away feeling like some real idiots sometimes. Wait, so we read this chapter for nothing?
You've been doing over and over and over again. And it's you reading the same words. They mean the same thing over and over and over again. Like, I have to know how to apply it. I can read the words on a page. I need to know how to make it make sense in my head. Okay, Professor, your turn.
Okay. Whenever. That's quiet.
So you're done?
You go, please.
Okay. So I'll go back again. So let me give you an example. You wanted examples.
Post the question.
All right. So here's the
Put it
strip.
up.
Here's the strip you see. And then the question says, you see this rhythm on the patient's cardiac monitor. What do you expect this patient to manifest? What is that question asking?
The one at the top?
Either one.
So
They have the same thing.
are you asking for the signs and symptoms that would be that patient would show?
They're going to have irregular heartbeat for sure.
Right.
And they're going to be for B. I would think they're going to be slower. They're more spaced, so the PQRS is more separated, so it's going to be on a slower rhythm. All right, Professor? So B?
And in B, look at how many QRSs there are here. 1, 2, 3, 4, 5, 6, 7, 8. So that's normal actually. So you have a normal ventricular rate.
It's normal.
Saying if I mean, what do you know about AFib? So to answer the question, you have to see, well, what is AFib? Okay, so you come down here.
Professor, isn't an AFib the ventricular rate is irregular?
That's what I thought.
AFib, that's atrial. We have atrial ventricular and the
AFib, atrial is, yes.
But what he just showed there was atrial. That's atrial fib.
Yes, AFib.
Right. So isn't the ventricular rate irregular?
No, it's
because
atrial.
in the
Let him explain, please. Let's really go.
I'm just saying in that particular example, because I can't give you thousands of strips on one question. So I can only post one strip, which is only, again, I'm restricted to what's in your textbook. So since that was the only strip available on your textbook, so I'm posting that same AFib strip. Then the question will be, what will be the patient's possible symptoms? So the answer is right here. So what will the patient look like to you? The thing about dysrhythmias is it's really the same because there's no dysrhythmia out there that causes a normal cardiac output. All of them will disrupt cardiac output. It's just a matter of what are unique to, let's say, AFib. So here, look at the clinical significance. So AFib does what? Miss Juliet.
Decreases in the cardiac output.
Okay, so therefore, if a patient has decreased cardiac output, what will be the manifestations? So does it even have to be specific to AFib if the question is about the decrease in cardiac output? So what are signs and symptoms of a patient who has decreased cardiac output?
Shortness of breath, dizziness, lightheadedness.
Very good.
Yes.
Okay, but on top of that though, that's not the whole thing that's not the end all of AFib, because there are no, if you remember the strip, there are no P waves, correct?
Yeah.
Those are all fibrillatory waves. So are the atria really contracting?
No, it doesn't seem that way.
Right, so therefore, what's happening to the blood in the atria, therefore?
It's remaining longer there.
Okay, so that's why we have clot formation as the other problem when a patient is in AFib. So on top of maintaining cardiac output, we have to make sure that this patient doesn't develop blood clots. And if they do, we have to catch those signs of them throwing blood clots. So we look for a sign of a PE, we look for signs of a stroke. Okay, so that's why it tells you here on the treatment. So how do we treat AFib? Okay, and it tells you here the goal is to keep the ventricular response normal. Okay, we don't want it going overboard in the hundreds or 200s. So these are all your goals. So therefore, without even looking at the treatment in the next paragraphs, what drugs will cause a decrease in ventricular rate? So what drugs can you use? Okay, so it tells you here drugs, beta blocker. So if I put the same question, the same strip, and I change the question now, which of the following drugs will be used to treat this type of dysrhythmia? How do you answer now?
It's a calcium channel blocker.
All right, there you go. So the questions will either be signs and symptoms, interventions, and sadly our interventions, this is cardiac, it always involves medications. We cannot treat the patient with therapeutic communication. Okay, they're in AFib. We can't say, do you want to talk about it? Or how do you feel? So sadly, it involves medications. There's no other way we can treat these patients. All right, and then how do you prevent stroke? How do you prevent blood clots?
Okay.
Anticoagulant therapy.
Okay, very good. So here it tells,
Nurse.
right, so when do we start anticoagulation?
As soon as it is discovered that they're having irregular.
Okay, here.
Okay.
Drug first to convert the patient to sinus rhythm, which calcium channel blockers, diltiazem drip is very common. That's almost the first thing you hang. We give them beta blockers, PO, twice a day. If they don't respond to that, we'll add amiodarone or dronedarone and then digoxin at the same time. However, they do digoxin if the ventricular rate is really fast, and then we start the anticoagulants, and then if still here, look at the treatment. So we give decreased ventricular response, that's the purpose of these drugs here. Then prevention of stroke, that's your anticoagulation. And then conversion to sinus rhythm, we have two possible ways to do that. Either you do cardioversion or ablation somewhere down here. Okay, here, now we have ablation.
Could you go over that that little area, ablation?
Oh, you want to, well, I really don't have, it's just a description, okay, of ablation. So how did they do this? So before this can be done, the patient has to have a electrophysiologic study, meaning in order to know which part you burn, you have to see, we have to find where that pathway is. So the purpose of ablation is to stop the pathways that are creating these signals, which is causing the AFib. So there are many of them, I'm sure, in the atria. As you saw on the rhythm, there were so many tiny squigglies there, which are not P waves. So therefore, not a single one of them are coming from the SA node. So there are multiple pathways that are where those things are coming from. So they bring the patient to the cath lab, do an electrophysiologic study. What it does is it basically maps out where the electrical impulses are coming from. And as soon as they see it, then they burn them. That's it. We're not performing the procedure. So all you're doing is just, all you need to know is how is it done. So basically, that's why I did not have any questions on it, because there's really no description on your textbook. However, cardioversion, which is more commonly done, is described here. How you prepare the patient for cardioversion. Okay, so that's why on the test question, these were there. And then you have here, warfarin is of course our drug of choice. However, there are alternatives, but remember that the alternatives they say here are for non-valvular AFib, meaning the AFib must not be caused by a valve problem. Meaning if you have mitral stenosis, aortic stenosis, more likely mitral versus aortic, because what causes AFib is if you have a congestion in the atria, and therefore it can't be a aortic or pulmonic problem. It's usually a tricuspid or a mitral problem.
Professor.
Yes.
Professor.
Uh-huh.
When you have AFib taking place,
right?
I heard you say maybe the patient has a clot. I want to ask if a diagnosis of AFib, so it immediately puts you on a blood thinner, right? Okay, because I know a situation where someone presented, and this was very close to home, presented with the dysrhythmias. They could feel, feel it in their chest. Went to the doctor, and it was only when they did the studies that they realized that that the clots were present. Only by they could actually see. It was only by that process, when they, whatever it is you just said, the study where they can go in and look and see what's happening, and it kind of like an emergency situation.
The visualization of the clot, though, is done by echocardiogram.
Right. Yes. Whatever that process was. And so that was the only way that they saw it and were able to set up the ablation. And then the ablation was done pretty quick.
All right.
So in the case then, Professor, what is warfarin is used if it's a case of a non-valvular AFib?
No. If it's a valvular AFib, you use warfarin only. Clearly here, if it's a valvular AFib, these guys here, which are dabigatran, apixaban, rivaroxaban,
okay,
are those are possible if it's non-valvular.
It's non-valvular, okay.
So here, just read the statement. Alternatives to warfarin are available in patients with non-valvular AFib. Examples include dabigatran, apixaban, and rivaroxaban.
Okay.
And what's good about these drugs? These require no routine blood testing and also no diet restrictions, unlike warfarin. So here again in your clinical associations or causes, here is valvular heart disease causing AFib.
Okay.
So my recommendation again, guys, is always think of an application. Okay, so again, my questions will always be what, a scenario. Okay, what do you do? What do you expect to see? Okay, how do you prepare this patient? Right? Well, what's the reason for this? You can answer those, then you can answer the question. And of course, you have to know how to read the topic of the question. Because if you're looking for, let's say, how many of you have reviewed the test and then you miss subtle things like further teaching, needs additional teaching. I can't even remember how many of you just disregarded those, one word that changes the answer.
Hence the reason. And what you're not seeing is people hitting us up with text messages asking, where are the questions? Is he going to put up some questions that we can look at? I can't be the only one asking that. My phone is lighting up all the time. When is he going to put up the question? We don't want to see a test, please. We just want to have an idea. We're missing what you're saying. You know, you said we're missing words. I feel like the lone voice in the wilderness, but I know that there are other people who are saying, oh my God, can we see a question? Questions, show us how to attack them. And I'm not going to say another word again for the night. Anybody else wanting this to happen is going to have to speak up.
Charmian, you saw 55 questions on the exam 3.
I don't want 55 questions, you know that.
Yeah, so it'll be...
I just want a couple, just a couple to teach.
Or 55, more time.
The drug dosage calculation examples, if you can probably do a few of the cardiac ones, or
you know, types of problems, it's the same dosage calculation problems that I'm putting up, just different numbers.
Okay, Professor.
We all did well on the dosage calculation. We were prepared, more prepared, because even if we got it wrong and send it back to you, you gave us feedback on how to fix or get to the correct answer. We don't have that opportunity here. It's just, okay, here's the test. If you apply it, if you know it, you know it. If you don't, you get it wrong. So there's no opportunity for correction prior to the exam.
Hands with dark skin. You mean for the math or?
No. As Charmian said, like sample questions for like cardiac questions. If you send maybe 10 and we can go over and see if we're able to answer the 10 before Friday.
Oh, okay, so we have, when is our next, tomorrow night?
But Tasia, giving us the question is one thing, but at least putting up two, just two, and kind of showing. So maybe, I don't know, I give up, I'm done.
Hold on, Charmian, one sec. Professor.
Yeah.
Just Juliet. I don't know if you can recall the questions that students were least able to respond to correctly. So maybe if you could, you're given different questions for the repeat, pull some of those questions and throw at us. Basically, I'm thinking that maybe that would kind of, because one of the things is, for me, Professor, I don't know for my colleagues, for me, I am not used to your line of questioning, but I try my best. Because, you know, every teacher, professor structures their question differently. So maybe if you want to pull among the highest incorrect answers you got to some of the questions from the last exam and throw at us, so we could maybe re-attack and re-approach the questions, it would be maybe a good place to start. Seeing that it's fairly new for us to be exposed to a certain type of questioning.
That's a good idea, Juliet.
Okay, cool.
Okay, try this question.
We're doing 25, Professor? 25?
25, right?
Okay.
So this is recall. Since you guys asked, that's it be some of it be recall. So this is an example of a recall question.
So, Professor, I thought that in third degree AV blocks, the P waves is going, gone.
No, that's second degree.
Oh, Jesus.
Professor, isn't in third degree AV block, which this is, right? Doesn't it also has ventricular, the escape rhythm, a ventricular escape rhythm?
No, don't confuse the two. So just do this one, because plus we never,
Ventricular escape.
yeah, we didn't discuss junctional dysrhythmias. So just the atrial, ventricular, sinus, and heart rhythm, which are also part of AB, or you can say, I guess, junctional dysrhythmias. So, Elaine, which one is this?
Professor?
Yeah.
Happening?
Yeah, I'm waiting for, who they call, Elaine? Or anybody. What is this rhythm?
I mean, we saw the.
Is it a second degree AV block?
Third degree.
No.
Third degree AV.
Third degree AV block.
So what is the what do you call those things? So remember how I said I thought it was third degree was going, gone.
No.
But no, that's second. So how would you, like, what is like a mnemonic or something that you would remember for this one?
For complete AV block, you have normal P waves. They are occurring regularly. And the QRSs, there's either 2 or only 3 in a 6-second strip. This is a 6-second strip. You only see 2 there. There's no PVCs. They're normal. You have normal P waves. You have normal QRSs. Okay, but you clearly see there's no QRS for every P. There are missing. Okay, and there's so many missing. This is third degree AV block. In first degree block, it's complete. Every P has a QRST. Every P has a QRST. The only thing wrong in first degree heart block is the PR interval is more than one big block. It's greater than 0.2 seconds. That's the only thing in first degree. So now you know first degree and third degree. Problem now is with second degree. There are 2 types. So this is what Taysha was saying. In second degree type 1, The first PR interval is long. It gets longer on the next one. And then finally on the third one, you lose a QRS. And repeat. So the next PR interval is more than 0.2. It gets longer on the next one, which is, let's say, 0.24 or longer. And then on the third one, you lose a QRS. You have a block. Second degree type 2. The PR interval again is long, but on the next one, it doesn't get longer. It stays the same. So you have long, longer, and then you lose a QRS again. You get another block. Repeat. Long, long block. That's type 2. Second degree type 2. Next question.
Great, thanks.
Okay, let me pull up the next question this time. Okay, try this. Miss Ashley.
Can you zoom in a little bit?
I can't with this app.
Okay, I'll try to look at it. I would say C.
Very good. That's the correct answer.
Go, Ashley.
You know,
Let's see. How did you come up with that, Ashley? Why did you pick C? What is this rhythm?
I'm sorry.
What is that rhythm?
I would say is that Afib?
I was hoping you knew because I thought that's how you came up with C because this is what rhythm? Anybody?
Is this sinus tachycardia?
Is it a tachycardia?
Right. So therefore, in your textbook, what did the book say about sinus tachycardia?
Gotta treat the underlying condition first.
Right. So therefore, you have to know how this is affecting your patient. They always based on symptoms. So the only way you know what the symptoms are if whether or not the patient's symptomatic is to check the vital signs. Okay, let me find another one. Okay, Bilin. Try this one. Number 17. And a variation of this question is, what if I don't put multifocal PVCs there? Instead, I put there an actual multifocal PVC.
Is it D?
Okay, hypokalemia. Or I could change this question to an intervention instead of this one, which is an assessment finding. So I'll change it to an intervention question. What would you do for this patient? You would, an intervention for a multifocal PVC. It would involve increasing potassium intake, right?
Yes.
Other known causes of PVCs are what? So let's go to your textbook. What are the other known causes of PVC? Atrial, let's go to ventricular dysrhythmias.
Alcohol, stress, low blood oxygen, and certain medications.
So here on page 769 tells you clinical associations for PVCs. They're associated with stimulants, coffee, smoking, and other medications. Others are exercise, emotional stress. Okay, so any of these, what if I put it in a select all and apply question? You can still answer that, right?
We had one, right? That was when you reduce stress, you reduce alcohol, and the coffee.
Okay, yeah. So similar question to that.
Well, it's making sense now. Only today.
Okay, I'll find another one. How about this one? Try number 15, Miss Dency. So this is again another recall question. So it's simply asking you what are the normal measurements of the waves and complexes.
I don't recall this one, Professor.
Okay, so let's try. Anyone else wants to volunteer? Is a T wave of 0.16 normal?
That's normal.
Yes.
Yes.
PR interval of 0.18.
No, that's abnormal.
PR interval.
Oh no, that's normal. PR. That's normal.
Okay.
Professor?
Hello?
I was looking at C.
No, that's normal.
C is normal. 0.34 for the QRST. 0.4 is 0.
Professor, I think it's D.
0.1 for QRST short.
Duration and QRS interval, right?
Yeah, I think it's D.
Okay, because intervals are how far apart are the QRSs, whereas QRS duration is how wide or how narrow is the QRS, correct?
Yeah.
Okay.
Right, so 0.14 seconds, that's what? How many? Only 3.5 small blocks. So that's the distance between QRSs.
Okay.
Heart rate would be what? If they're that close apart, what would be your heart rate? Usually in the 150s, maybe 200.
This will be very quick.
Okay. All right, so that's a recall. Let me find another one. How about an ICD question? Let's try Allison. 12.
Would it be A? Because you can't move the shoulder or the arm on the side where it was implanted right away?
Because he had just had it put in, right? And on the table, this is contraindicated. It says there, follow activity restrictions, and this is one of them, until told to do so by the surgeon. All right, so let's try pacemaker. Miss Frances Belez, number 11.
Hello?
Uh-huh.
I want to say I'm between C and D.
Okay, so which one is it?
I want to say D more because it fluctuates with the pacemaker.
Again, please read the chart. Okay, this is old news. I know we see signs everywhere in the hospital that, you know, if there's a microwave in use, you know, people with pacemakers, those signs are in the 70s.
It's B. I would choose B.
Boy?
Yes.
Look at that sentence though. It says, I will notify the airlines when I make a reservation. Does the chart say we call the airlines? Airlines don't care whether you have a pace.
No, not the airlines.
But who cares though? Who will care?
TSA.
TSA will, because you have to go through the monitor.
Yeah, not American Airlines. Okay, it's really when you go to
avoid cooking.
to airline security, those guys you tell because they're the ones with the magnet. So what's the answer here?
C seems most to me.
Okay. So it's actually the same as the other question with the ICD. ICD pacemaker, they put in the same spot. They just have different functions, but the restrictions are the same. So they can shower, no problem, but a bath, probably not because you're now soaking the incision, right?
Right.
Showering is fine. There's no contraindication with the shower as long as you don't lift your arm up. So probably you can't rub the shampoo on your head with both arms. No, you can just shampoo with the other arm, with the right arm. Okay. So these are examples. Okay, another one. Miss Blaze. Let's try this one, another AFib question. So this is regarding the therapy. So we discussed earlier what are the sequence of how we treat AFib. So we said we start with drug therapy first and blah, blah, blah. Number 9. Miss Blaze? Hello?
The question isn't on the screen anymore.
Oh, sorry.
I honestly don't know.
Try. Let's say this is now the test question. So which one you have to pick something. So the goals of AFib treatment, what are they again? First is to decrease the ventricular response. We don't want any rapid ventricular response. Second was to prevent clotting. Third is to convert the patient back to sinus rhythm.
A? Question mark?
Before cardioversion, what will be done first? So what was the order of the therapy? So we saw drug therapy first, namely calcium channel blockers, beta blockers, digoxin, amiodarone, and then they didn't respond to drug therapy. And now the patient continues to be in AFib. So what's the danger here? Because you can't really perform cardioversion unless you ensure something first.
C.
What letter?
C.
Okay, very good. So you have to do anticoagulation first because in the first place, you can't do cardioversion unless you're assured that there is no clot. So we can't just perform cardioversion without ensuring that there's no blood clot because the cardioversion, the procedure might dislodge one. So the patient may have a stroke or a PE during cardioversion.
Professor, that makes sense. Obviously, we know that, but again, that was the fact that the question is telling me that the drug therapy wasn't useful for the patient. I automatically erased both medications.
Yeah, I did too, because I assumed warfarin is a drug.
It doesn't work for the patient, so I assumed right away it's either A and D. But obviously, before D, you should do A. That was my thinking.
Ah, okay. So you would it would have helped you if the drug therapy here was specified as to what drug therapy it wasn't responsive to.
Yeah, probably because again, I saw the drug therapy and right away I discarded 2 of the drugs.
Ah, okay. All right. Well, that isn't my question, so you won't see it like that. Want some more?
Yes, please. Shamandola. Okay, I need to pass this exam on Friday. Thank you very much.
What's that?
I'm quiet.
No, but your laugh was distinctive. Okay, who's next? Let's try Debbie Gibson. Try number 8.
A, an increase in the patient's heart rate.
There, very good.
Okay.
So this is an evaluation question. When you're asked about whether it's effective, whether it's a patient statement or a clinical finding like this. So those are evaluation questions. And according to NCLEX, that's actually the highest level of learning. If a student can evaluate, that means you know the entire process. Because look at it, if you, in order to evaluate, that means you understood assessment, right? You understood interventions. So you covered both, because that's the only way you can answer an evaluation question, meaning you have gone through assessment and intervention first. Okay, let's try this one. Wants to go next? Jennifer.
Oh, yeah, I was just about to say me.
Number 6.
Two meters per minute, except the peer interval is 24. Intervention by nurses to the 72 24 seconds. Hold measuring increases heart rate. I want to say A.
Okay, if you have, it says normal cardiac rhythm and the heart rate is 72. Is 72 low, normal?
Normal.
Is normal.
And it says here,
I'll use that one too.
except the PL interval is
0.24 seconds.
okay. So is that normal, low, high?
High.
High.
That's high.
0.2. So what rhythm is this? 72. And we have a prolonged PR interval. So what is this rhythm?
I agree. It's a first degree block.
All right. So what did the textbook say about a first degree block?
Don't you watch them to monitor the patient?
Atropine.
It's asymptomatic.
So you monitor the patient, no?
So what were your answers? I am hearing different things.
I chose D.
Okay. D. Well,
I say D, monitor.
Yeah, I was gonna say D too.
atropine is not indicated here because the patient really has no symptoms. And this is first degree AV block. And it says on first degree AV block, for the patient with symptoms, you give atropine. Patient clearly has no symptoms. So the only thing to do is watch and see. Let's try. All right, let's try a prioritization question. Charmian, do number 22.
Ah, um,
So this is a management of care question. And how do you answer things like this? It's the same as, let's say, which symptom would you, if this was changed to a symptom question, the symptom question, it would be.
I'll go with D.
Okay, that's correct. So you always see which patient will die first unless you see them, correct?
Yeah.
Okay, so follow the basic rules in management of care questions. So it's ABC. If that doesn't work, because obviously all patients have ABC. Second is acute versus chronic. That again doesn't seem to be applicable because all these conditions are acute. Third is you can do expected versus unexpected. Will that work? Yeah, that will work, right? Because the letter B patient, the one with this first degree block, the rate is 60. However, they're dizzy when ambulating. So first degree block, you simply have them sit down and they'll be fine. However, this patient in D has an ICD and fired 3 times. So therefore, what did they have? Why did the ICD fire? And what is an ICD, Miss Bibi? Bibi still here?
Hi, Professor. What was your question?
What an ICD and why did it fire?
Okay, so ICD, when the ventricles are irritatable, you use it when there is a block, so you want heartbeat, is similar to a pacemaker.
No, this is a
No.
cardioverter defibrillator. So, first of all, who gets them? Who gets ICDs? Yeah. Joshua. Or Miss Manon. Who gets ICD?
Well, it says the defibrillator.
Someone's bradycardic?
No, go back.
Somebody who has CAD. The history of CAD.
Only
Someone
like I already have CAD.
who have abnormal heart rhythm.
Tachycardia, ventricular tachycardia.
Or
An arrhythmia.
Sudden cardiac death.
Okay, so what are causes of sudden cardiac death? So these are people who have a high risk of developing two rhythms, VFib or VTAC. These are two life-threatening rhythms. So that's why the doctor puts an ICD in them, because these two rhythms need to be defibrillated. Are you with me so far? So
Yes, Professor.
they need defibrillator inside these patients so that when they develop, the ICD fires. And then that's your indicator there that it fired 3 times. So at least how many times did they develop VFib or VTAC? At least 3 times. So therefore, they need to be seen first because you have an amiodarone due, and amiodarone is the drug of choice for those ventricular dysrhythmias. Okay. Alrighty. It's 8:06. It's past my bedtime. Really, I have to record the lectures. Any other? Oh, but we still have tomorrow for those who are available tomorrow. We'll continue. It'll be until 7:45 tomorrow, 6 to 7:45, because I have class at 8.
Okay.
Professor, thank you.
And then we have class on Wednesday.
Thank
And
you, Professor.
Thank you, Professor.
Thank you, Professor. Have a good night.
Professor. Have a good night.
Good night.
Bye.
Bye.
Thanks a lot.
Alrighty.